Hello and welcome. We're so happy to have you join us today. My name is Megan Kilkenny and I'm the Program Manager for the Congenital Hyperinsulinism Center at CHOP. I want to thank you all for joining us here virtually to learn more about the new advances in the diagnosis and management of congenital hyperinsulinism. This will be presented by Dr. DeLeon Crutchlow. Dr. DeLeon Crutchlow is the Chief of the Division of Endocrinology and Diabetes and the Director of the Congenital Hyperinsulinism Center here at Children's Hospital of Philadelphia. Please feel free to ask questions throughout the presentation through the Q&A chat feature, and we will have time at the end of the presentation to address and discuss them further. If you wish to claim CME credit, you will receive a survey at the end of the presentation. Please note this link is only active for 48 hours. Thanks again, and we hope you enjoy this presentation.
Good morning.
Diva.
Good morning, everybody. Welcome and thank you for joining us this morning. We're going to discuss new advances in the diagnosis and management of congenital hyperinsulinism, and we have left plenty of time at the end to discuss your questions. These are my disclosures. I want to emphasize that I would not be discussing any of these topics related to my relations with these commercial interests. The learning objectives for today are: 1, to describe the clinical manifestations, genetics, and natural history of congenital hyperinsulinism. 2, to review recent advances in the medical and surgical management of hyperinsulinism. And 3, to review the long-term outcomes and follow-up of children with hyperinsulinism. I would like to start by giving you a brief overview of the definition and diagnosis of hyperinsulinism. It was in the mid-1950s when a report by McGuire first described the first cases of congenital hyperinsulinism in what he referred to as idiopathic spontaneously occurring hypoglycemia in infants. We had more recently the opportunity to investigate the family described by McGuire and had confirmed that that family had what we now know as congenital hyperinsulinism. Shortly thereafter, the familial nature of this condition and the fact that hypoglycemia in affected individuals can be precipitated by consumption of amino acids was described by Cochrane in a publication from the Journal of Clinical Investigation. But it was not until 1960 when the development of the insulin immunoassay by Yalo and Burson made it possible to make the connection between idiopathic, spontaneously occurring hypoglycemia and endogenous insulin. But in 1975, with this knowledge, the term of idiopathic hypoglycemia was replaced by congenital hyperinsulinism, as we refer to this condition today. And publications from Heyman and Pagliara, Stanley at Baker here at the Children's Hospital of Philadelphia, and Ashley Green at Great Ormond Street define the criteria for the clinical diagnosis of hyperinsulinism, as evident by hyperinsulinemia, hypoketonemia, hypofree fatty acidemia, and a hyperglycemic response to glucagon. And we're going to discuss these diagnostic criteria in more detail later. Until 1981, congenital hyperinsulinism was considered a disorder of embryogenesis based on histological findings in the pancreas of babies affected by this condition. But in 1981, seminal publications described that what was believed to be nisidioblastosis was indeed normal findings in the pancreas of normal newborns, and therefore the concept of hyperinsulinism as a disorder of embryogenesis was abandoned. In the late 1980s, it became apparent from findings of the evaluation of the histology of pancreatic specimens of patients that require pancreatectomy, that there were two types of hyperinsulinism. There was a diffuse histological type and a focal form of the disease. But the elucidation and definition of these subtypes was not possible until later in the mid-1990s. The first genetic defects were discovered, and the first publication was the discovery of sulfonylurea receptor 1 mutations causing the most severe forms of hyperinsulinism. A very important year in the history of congenital hyperinsulinism was the development of 18-fluorodopa PET imaging to localize focal lesions in 2004, because this forever changed the management of children affected by the focal form of the disease. And since the 2010s, we have seen a significant expansion on the ability to do genetic testing for the multiple different forms of hyperinsulinism by using multiple gene panels that allow for testing for multiple different genetic defects in one single test. Congenital hyperinsulinism is the most common cause of persistent hypoglycemia in neonates, infants, and children. In the neonatal population, we have estimated that hyperinsulinism, either congenital persistent hyperinsulinism or transient hyperinsulinism, accounts for about 3/4 of all cases of persistent hypoglycemia in neonates. We do not know the true incidence of hyperinsulinism, but it has been estimated in the United States and in Europe that the incidence is about 1 in 20,000 to 1 in 50,000 live births. I should emphasize that this figure refers to the severe cases and not the whole population of children affected with hyperinsulinism. But of the severe cases based on this incidence, it is estimated that in the United States, there are about 80 new cases every year. Hyperinsulinism is caused by dysregulated insulin secretion from the pancreatic beta cells and can be the result of perinatal factors, as is the case in perinatal stress-induced hyperinsulinism. Hyperinsulinism can also be just one component of a syndrome. More commonly, the syndromes associated with hyperinsulinism are Beckwith-Wiedemann syndrome, Kabuki syndrome, and Turner syndrome, but the list keeps growing every year. The monogenic defects responsible for persistent congenital hyperinsulinism involve mutations in genes that are important for the regulation of insulin secretion, and they are dominant and recessive forms, as we're going to discuss later. But let's spend some time talking about how the diagnosis of hyperinsulinism is established. And it's important to emphasize that to make the diagnosis of hyperinsulinism, we do not only rely on evidence of hyperinsulinemia, but also on evidence that insulin actions are inappropriately turned on during hypoglycemia. This would include evidence that insulin is suppressing lipolysis, as demonstrated by low plasma-free fatty acids at the time of hypoglycemia, evidence that insulin is suppressing ketogenesis, as demonstrated by low plasma beta hydroxybutyrate during hypoglycemia, and evidence that insulin is suppressing glycogenolysis, as demonstrated by a glycemic response to a pharmacologic dose of glucagon during hypoglycemia. So we're going to now talk about the sensitivity and specificity of these different tests to demonstrate the importance of not basing the diagnosis exclusively on the plasma concentration of insulin. This is important because insulin is not always high during hypoglycemia in hyperinsulinism. And that's clearly demonstrated by this data generated here at the Children's Hospital of Philadelphia. On the red squares are insulin concentrations in plasma of neonates and infants with hyperinsulinism, and in the circles are insulin concentrations according to plasma glucose concentrations in normal control. As you can see, in some of the hyperinsulinism cases, plasma insulin concentrations are clearly elevated at hypoglycemia. However, for a great majority of the cases, the plasma insulin concentration is in the range that your laboratory may report as a normal fasting insulin concentration. However, any detectable insulin at the time of hypoglycemia is inappropriate and has a specificity for hyperinsulinism of 100%. However, the lack of detection of insulin during hypoglycemia does not rule out hyperinsulinism. As you can see, the sensitivity of a detectable insulin is only 82.2%. So in some patients with hyperinsulinism, insulin is not detectable at the time of hypoglycemia. This is similar for C-peptide. Again, the specificity of a C-peptide concentration greater than 0.5 nanograms per ml for hyperinsulinism is 100%, but the sensitivity is 88.5%. A test with the better sensitivity and a specificity again of 100% for the diagnosis of hyperinsulinism is the evidence that ketogenesis is suppressed, as demonstrated by a plasma beta hydroxybutyrate of less than 1.8 millimolar per liter. As you can see in this graph, the data depicted in the first figure that I show you now graph according to the concentration of plasma beta hydroxybutyrate can more clearly separate the patients with hyperinsulinism with those of controls. So beta hydroxybutyrate is the most sensitive and specific test for the diagnosis of hyperinsulinism. Of course, this is in combination with demonstration that free fatty acids are also suppressed, and the free fatty acids levels of less than 1.7 again are 100% specific for hyperinsulinism. Another test that helps establish the diagnosis of hyperinsulinism is evidence that IGF-BP1 is suppressed during hypoglycemia. The sensitivity of a plasma IGF-BP1 level of less or equal to 110 nanograms per ml is 85%, and the specificity is 96.6%. But in the majority of the institutions, you would have to wait for these laboratories to be back for a few days and sometimes even a week or longer. So a very useful test that one can do at the bedside to make the diagnosis of hyperinsulinism is the glucagon stimulation test. In this test, during hypoglycemia, when the plasma glucose is less than 50 milligrams per deciliter, a pharmacologic dose of glucagon of 1 milligram administered either intravenously or intramuscularly elicit a glycemic response and a delta or an increase in the glucose concentration of greater or equal to 30 milligrams per deciliter has a sensitivity of 89% and a specificity of 100%. So this is a very useful test to be done at the bedside that can during a very short time, help with establishing the diagnosis of hyperinsulinism. But it's very important that an appropriate dose of glucagon is used to avoid false negative tests. So we recommend a pharmacologic dose of 1 milligram independent of the infant or neonate age or weight. We're going to now briefly review some of the subtypes of hyperinsulinism that I mentioned earlier. The first one is perinatal stress-induced hyperinsulinism. I like to use this picture on your screen to demonstrate the fact that hyperinsulinism comes in various sizes and appearances. If I show you this picture and ask which of these two babies have hyperinsulinism, most of us will point to the baby on the right, the larger baby. However, in this case, the baby affected by hyperinsulinism is the smaller baby. And this is a very frequent occurrence, perinatal stress-induced hyperinsulinism. It is estimated that can affect up to 50% of at-risk neonates, including babies born small for gestational age and babies born with IUGR or intrauterine growth retardation. We characterize a cohort of about 98 babies with perinatal stress-induced hyperinsulinism at our institution, and I'll describe to you some of our findings. We found that 75% of these babies were males, so there seems to be a predominance of male infants affected by perinatal stress-induced hyperinsulinism. In our cohort of 98 patients, prematurity was identified in 33.6% of the affected babies. 33.6% were babies born small for gestational age or with intrauterine growth retardation. 32.7% of these babies had greater than a standard resuscitation, indicating perhaps perinatal asphyxia. And in 18.7% of the cases that we evaluated, there was a history of maternal preeclampsia. Although the mechanism responsible for perinatal stress-induced hyperinsulinism is not well known, we had proposed that these perinatal stressors impair the normal process for beta cell maturation, and this leads to a prolongation of the transitional hyperinsulinemic state after birth. The clinical course of perinatal stress-induced hyperinsulinism can be highly variable and span from very mild and transient hyperinsulinemic hypoglycemia to very severe hyperinsulinemic hypoglycemia with high glucose requirements. In the cohort of 98 patients that we recently evaluated, the mean glucose infusion rate required to maintain euglycemia was 12 milligrams per kilogram per minute. The great majority of cases are responsive to diazoxide. In the cohort of 98 patients that I have referred to, 81% of those babies were successfully treated with diazoxide. The hallmark of perinatal stress-induced hyperinsulinism is that these cases resolve spontaneously, sometimes within days, and in other cases, it can last up to 3 to 4 months. In the cohort of 98 patients that we had evaluated, the median age when there was demonstration of resolution was 210 days. Importantly, the outcomes of babies with perinatal stress-induced hyperinsulinism can be devastating for these babies and not necessarily different than the neurological outcomes of babies with the persistent forms of hyperinsulinism. It has been shown by other investigators, but from our cohort of 98 babies with perinatal stress-induced hyperinsulinism, in 51% of the cases, the parents had concerns about development. 40% of these babies had speech delays. 26% had learning disabilities, and 41.5% have behavioral issues. So it's important to have this in mind, particularly because there's no doubt that these babies are already at high risk for poor outcomes. So the hyperinsulinism can make those outcomes even more severe. So diagnosis and prompt treatment is necessary. The second subtype of hyperinsulinism that I wanted to briefly review is hyperinsulinism associated with Beckwith-Wiedemann syndrome. As you know, Beckwith-Wiedemann syndrome is an overgrowth syndrome with described physical characteristics including macroglossia, ear pits, abdominal wall defects that go from umbilical hernias to omphalocele and also hemihypertrophy. However, sometimes those physical characteristics can be very subtle. Therefore, the suspicion for Beckwith-Wiedemann syndrome should always be in the back of our mind when we evaluate a baby with hyperinsulinism. Beckwith-Wiedemann syndrome, as you know, results from various genetic and epigenetic anomalies in the imprinted 11p15.5 chromosomal region that are depicted here on the bottom right. This region of chromosome 11 is where insulin and also the genes encoding the beta cell KATP channel are encoded, but this is also a very highly imprinted region of chromosome 11 where genes that promote growth, such as IGF-2, are only expressed from the paternal allele, and tumor suppressor genes, including H19 and CDKN1C, are expressed only from the maternal allele. So it's an imbalance of the tumor suppressor genes and the growth promoting genes that result in some of the physical manifestations of Beckwith-Wiedemann syndrome, particularly the hemihypertrophy, and that we think are involved in the massive expansion of beta cells mass that can be seen in cases with hyperinsulinism. Hyperinsulinemic hypoglycemia can be seen in up to 50% of cases with Beckwith-Wiedemann syndrome. And again, the severity varies in this population. The hyperinsulinism can be transient and responsive to treatment with diazoxide, but can also be severe and persistent, in some cases requiring pancreatectomy because of the inability to control the hypoglycemia. Those severe and persistent cases are more frequently due to mosaic paternal uniparental isodosomy for 11p. And in these cases, we had the opportunity to evaluate the pancreatic histology and has seen a marked expansion of the beta cell mass, as demonstrated in this histological section on the right, that showed marked expansion of the endocrine tissue in the pancreas. But we're going to spend the rest of the time talking about the monogenic forms of congenital hyperinsulinism, in which the most severe of them are cases resulting from inactivating mutations in either one of the two genes encoding the beta cell KATP channel. These genes are ABCC8 and KCNJ11. This is the typical presentation of congenital hyperinsulinism with large birth weight because of the growth promoting effects of insulin in utero, severe neonatal hypoglycemia. Typically, these babies have, but not always, high glucose requirements to maintain euglycemia that can be up to 25, 30 milligrams per kilogram per minute. The hallmark of KATP hyperinsulinism is the lack of response to treatment with diazoxide, and very frequently these cases require pancreatectomy. That's why it became incredibly important to come to the realization that histologically there are two subtypes of KATP hyperinsulinism, diffuse and focal hyperinsulinism, because the surgical outcome in these two subtypes are very different, as we're going to see later. The KATP channels of the beta cells play a very important role in the regulation of insulin secretion. In conditions when plasma glucose is low, below the threshold for glucose-stimulated insulin secretion, beta cell metabolism is low, and the low ATP to ADP ratio in the beta cell keeps the KATP channel open. This keeps the plasma membrane hyperpolarized, and insulin is therefore not released. However, when plasma glucose increases above the threshold for glucose-stimulated insulin secretion, which in the human is about 85 milligrams per deciliter, increased glucose metabolism in the beta cells results in an increase in ATP production, and the higher ATP to ADP ratio closes the KATP channel, depolarizing the plasma membrane, which allows for voltage-dependent calcium channels to open, calcium to come into the cell, and the increase in cytosolic calcium results in insulin release. In KATP hyperinsulinism, these mutations prevent the expression of the channel at the plasma membrane, and therefore the plasma membrane is constitutively depolarized. Cytosolic calcium is high, and insulin is released independent of plasma glucose concentrations. As I mentioned previously, there are two distinct histological types of KATP hyperinsulinism. In the classical diffuse form of hyperinsulinism, which is inherently, in most cases, as a recessive condition, biallelic recessive mutations in either ABCC8 or KCNJ11 result in a normal beta cell across the pancreas. So all the beta cells in the pancreas are affected. Histologically, the pancreatic islets look exactly like normal islets in terms of size and morphology. However, the hallmark histologically is finding of enlarged nuclei in beta cells throughout the pancreas. To talk about focal hyperinsulinism and the mechanism responsible for this form of KATP hyperinsulinism, we have to again talk about the short arm of chromosome 11. I told you when I was discussing Beckwith-Wiedemann syndrome that these KATP channels and also insulin are encoded in this short arm of chromosome 11, but a region adjacent to these genes is highly imprinted with IGF-2 expressed only from the paternal allele, and P57 and H19, which are tumor suppressor genes, expressed only from the maternal allele. Focal hyperinsulinism results from a two-hit mechanism. The first event is the inheritance of a recessive mutation from the father, so in either ABCC8 or KCNJ11. This recessive mutation in the heterozygous state does not have a consequence. This patient would be just a carrier. However, in the presence of a second hit with loss of heterozygosity and loss of the maternal short arm of chromosome 11, there is expression of this recessive mutation from the father and a double dose of expression of IGF-2 with the absence of expression of the tumor suppressor genes that are normally expressed only from the maternal allele. So this results in beta cells that express abnormal KATP channels and now have the potential to proliferate to form this adenomatous lesion that can be removed and cure the focal hyperinsulinism, as we're gonna discuss later. We're now gonna talk about treatment of hyperinsulinism, and before I discuss our proposed approach to management of these children, I wanted to give you a brief overview of the history of the treatment of hyperinsulinism. It was in the mid-1960s when Drash and Wolf first described the use of diazoxide for the treatment of hyperinsulinism. At the time, diazoxide had been developed as a treatment for hypertension. However, its use for this indication was quickly discontinued when hyperglycemia and frank diabetes was noted to be an adverse event, which prompted an interest in using this medication for treating hyperinsulinism. And until now, at least in the United States, diazoxide is the only Food and Drug Administration approved treatment for hyperinsulinism. Drash and Wolf described that the use of diazoxide allowed for managing about 56 to 60% of the cases of hyperinsulinism without surgery. About 10 years later, then the use of somatostatin was proposed in the treatment of hyperinsulinism in a seminar publication in the New England Journal of Medicine. And with the development of longer-acting somatostatin analogs, particularly octreotide, somatostatin use because of its short half-life was abandoned. Browning and et al. Described the use of octreotide to treat hyperinsulinism, and in their cohort, they demonstrated that they could prevent the need for surgery in about 29% of the cases treated. Again, 2004 marked the year in which we were now able to reliably identify focal hyperinsulinism and cure those patients from the hyperinsulinism. Other treatment options had been suggested in multiple publications with various success. In 2008, Monique and colleagues described the use of continuous glucagon infusions subcutaneously to manage hyperinsulinism that could not be managed with octreotide and diazoxide. However, the long-term use of this, as many of you know, is limited by the fact that glucagon, the currently approved formulations, are not stable in solution. Longer-acting somatostatin analogs have been introduced in the market for other indications and had been used off-label for the treatment of hyperinsulinism. These include lanreotide and long-acting octreotide. And multiple other investigational drugs have been proposed, but have not had a lasting impact in the management of these children. Importantly, in 2014, there was a publication in the New England Journal of Medicine that described the use of sirolimus to treat severe hyperinsulinism, but it had quickly become apparent that the side effects and the effectiveness of this treatment for hyperinsulinism does not justify its use, at least in our opinion. Excitingly, currently, there are multiple drugs under development, both in the preclinical and clinical space, so we anticipate that within the span of 5 years, we will have new tools for the medical management of hyperinsulinism. So I look forward to sharing some of this with you in the near future. So let's go back and talk a little bit about the goals of therapy in hyperinsulinism. The immediate goal is to promptly restore the plasma glucose to the normal range to prevent brain damage from hypoglycemia. The midterm goals should be guided to identify the optimal treatment regimens according to the type of hyperinsulinism, and we'll talk some more about this, and to maintain normal glucose concentrations while encouraging normal feeding and diet in these babies. And of course, the long-term goal of therapy is to prevent brain damage from hypoglycemia, but also to promote normal life and development. The quickly establish the diagnosis and the stabilization of plasma glucose and the prevention of further episodes of hypoglycemia is extremely important. And more frequently, this will require intravenous dextrose, not only acutely, but also following with a continuous infusion to prevent further episodes, to prevent brain damage. And including this video here, illustrating the fact that the signs and symptoms of hypoglycemia can be highly variable in neonates. This baby was having these episodes that were failed to be discovered to be caused by hypoglycemia, and this baby underwent severe brain damage because of the delays of diagnosis and prompt management. Step 2 in the management is the confirmation of the diagnosis, and we earlier reviewed the diagnostic testing for hyperinsulinism, but also to monitor plasma glucose very closely to prevent further episode of hypoglycemia. Talking about this, we should be aware of the limitation of the point-of-care glucose meters. While very useful to be used at the bedside, they are inaccurate and should not be used in isolation. Step 3 is to determine what support is needed and to prepare to deliver it. So these babies frequently would need central lines to administer highly concentrated dextrose to prevent hypoglycemia, and we should be prepared and not delay the placement of central lines when needed. It's extremely important to allow the baby to continue normal feeding, whether there is a breastfeeding, if that's what the family has chosen to do, or bottle feeding. Feeding should not be used to manage the hypoglycemia because this would inevitably result in feeding aversion, as we're going to see later. And we should consider intravenous glucagon if the glucose infusion rate required for preventing hypoglycemia is very high. So glucagon can be used as a short-term solution to manage the hypoglycemia in babies with hyperinsulinism. We use it to decrease the high glucose infusion rate required by this baby and therefore preventing fluid overload. We use a dose of 1 milligram per day continuously in 24 hours periods. However, more recent study has shown that lower doses may be as effective. And this effectively decreases the glucose requirement, as demonstrated by this data on the right from a publication that we published in 2018 demonstrating the effectiveness on intravenous glucagon in reducing the glucose infusion rate required by babies with hyperinsulinism. But one should be aware of potential side effects of glucagon. In our cohort of patients that we described, 13% had nausea and vomiting. A rare side effects is necrolytic migratory erythema. The major limitation is the fact that the available formulations crystallizes in tubing. This picture on the right depicts the necrolytic migratory erythema that can be seen in patients treated with glucagon, not different than what is seen in patients with glucagonomas. Let's talk a minute about the individualized treatment plan. Should be according to the genotype, and therefore genetic testing results are going to become extremely important, but also according to the phenotype, according to the clinical manifestations. This precision medicine obviously requires then a comprehensive investigations to understand all aspects of the condition, both genotyping and phenotyping. It would also require that we have different treatment options because one treatment modality may not fit all. And, as we had discussed earlier, treatment options are limited currently, but will be, we hope, more treatment options available in the future. So is it precision medicine possible for hyperinsulinism? I would say yes, absolutely. For focal hyperinsulinism, this is absolutely what we do. And sort of, but not for non-focal forms of the disease because of the limited number of therapies that we have available. Moving on to step 4 of the management approach then is obtaining additional diagnostic data. So phenotyping data and genotyping data. Step 5 is then initiation of the first line of therapy once we are satisfied with the diagnostic data that we have, and the first line of therapy is diazoxide 1 because this is the only Food and Drug Administration available medication, but also because the treatment with diazoxide serves as a phenotyping test, as we're going to see later. We also have to prevent and monitor for side effects of therapies. So for diazoxide particularly should always be used concomitantly with diuretics. Potential cardiac side effects should be prevented by appropriate evaluation of the cardiac status of the baby. Step 6 is then to determine diazoxide responsiveness, and we'll walk through these steps. So first, let's talk about molecular diagnosis. It's important for determination of the type of hyperinsulinism and also for prognostication. More than 12 causative genes have been identified in hyperinsulinism, and some of them are illustrated on the figure to the right, depicting the pathways of fuel-stimulated insulin secretion. As you can see in bold, the genes involved in hyperinsulinism affects all of these pathways in one way or another. Next generation sequencing panels are now available in multiple laboratories that allow for testing for all of these genes in one test. However, we propose that the right approach to molecular diagnosis should be a stepwise approach in which one quickly tests for the possibility that the mutations are in the genes encoding the KATP channel, because this would allow to identify those babies that should be considered at risk for having focal hyperinsulinism. So a two-tier testing approach would allow for rapid investigation of ABCC8 and KCNJ11, followed then by the next generation sequencing panel testing other genes. Testing is also available for syndromic causes of hyperinsulinism, and some of the panels include testing for those syndromic forms, particularly for Kabuki syndrome. But access to molecular testing continues to be a limitation because of costs and in other places availability as well. But the major limitations of molecular diagnosis currently are interpretation of the results because of the frequency of variants of unknown significance, to having access to large databases of mutations, like, for example, the one that we have here at the Children's Hospital of Philadelphia, allows for interpretation of the testing results at another level that you may not get from the testing laboratories. Another limitation in the molecular diagnosis is the fact that the frequency of negative results, even when one tests for all these genes, is quite high. In the diazoxide responsive cases, about 64% of them have negative genetic testing results, while in the diazoxide responsive one, it's more frequent that we do find a mutation, because the majority of these cases are going to be cases with mutations in the KATP channels. This figure just depicts the genotype of 814 cases from our series here at the Children's Hospital of Philadelphia. Overall, 57% of all cases were due to KATP channel mutations. If we divide these two in two cohorts, those that are diazoxide unresponsive on the left, you can see that the majority of cases are again due to KATP channel mutations, and only about 10% of the cases have negative genetic testing results. And on the right, on the disoxide responsive cases, the larger percentage of patients have no identified mutation, and the most frequent defects when found can be seen on the right, including dominant mutations in the KATP channels, the GLUT1, which is responsible for the hyperinsulinism, hyperammonemia syndrome as well. So moving along with treatment, a few words about disoxide. As I mentioned before, this is the first line of therapy. The dose range used for disoxide is between 5 to 15 milligrams per kilogram per day. Because of the long half-life, disoxide can be dosed twice a day. There's no need to dose disoxide more frequently. In the United States, we have only a suspension available. In other areas of the world, capsules can be obtained for the older patients. The mechanism of action of disoxide is through activation of the KATP channel via the sulfonylurea receptor, and therefore the majority of cases with inactivating mutations on the KATP channels do not respond to therapy with disoxide. A few words about side effects. The most frequent side effect, as shown by these pictures of two patients of mine on the right, is hypertrichosis, which affects about half of the patient, is highly dose dependent, and becomes a side effect, while not medically relevant, is very bothersome for the families and the patients when they become older because of the changes on their physical appearance. But the side effect that we worry more frequently is fluid retention and significant edema, which even in the population of children that we have treated, having in mind that we are very aggressive in using diuretics to prevent fluid retention, was seen in a frequency of 18% of our patients. Pulmonary hypertension has been described as a side effect of disoxide. In our cohort, the frequency was lower than in other cohorts, and it was only 2%. And I believe this is lower because we screen for babies that are at higher risk and prevent using disoxide in those high-risk babies. And we are also very aggressive using diuretics concomitantly with disoxide from the beginning, rather than waiting for fluid retention manifestations. Other side effects include suppression of appetite. Hyperuricemia can be seen in 5% of the cases, and bone marrow suppression, including neutropenia in 16% in our cohort, and thrombocytopenia in 5%. So as you can see, some of the side effects are severe enough that will prevent the use of disoxide long-term. But the most important message that I want to give you with today is how to define disoxide responsiveness. Very frequently, disoxide responsiveness has been defined as the ability to maintain normal glycemia on a feeding schedule that is appropriate for age. However, this definition lacks precision, varies markedly according to age, because the duration of fasting tolerance is not a fixed value in children with hyperinsulinism. And more importantly, using this definition may result in a misclassification and a loss of opportunities to cure focal cases, because the first step in establishing the likelihood of focal hyperinsulinism is establishing that the case is disoxide unresponsive. So I propose that we abandon this definition and rather use the definition that disoxide responsiveness is demonstrated when you demonstrate the correction of fasting hypoketotic hypoglycemia, demonstrating that the plasma beta-hydroxybutyrate increases before the plasma glucose drops below 50 to 60 milligrams per deciliter. Of that, the patient is able to fast greater than 18 hours with normal plasma glucose, with some increase in beta-hydroxybutyrate. So in addition to demonstration of the correction of the fasting hypoketotic hypoglycemia, one should also demonstrate the correction of food-induced hypoglycemia is present. For example, in a patient that has protein-induced hypoglycemia as a phenotypic manifestation of the hyperinsulinism, one should demonstrate that the disoxide is preventing this hypoglycemia induced by protein. So putting it all together, once the diagnosis of hyperinsulinism has been established, the first step should be a trial of disoxide. Again, because of the long half-life, one should wait at least 5 days before testing for responsiveness by doing a safety fast. If the criteria for disoxide responsiveness are met, then disoxide should be continued. And the duration of therapy is going to be determined according to whether you suspect that the hyperinsulinism is transient or not. If there are clinical evidence of perinatal stress, so perinatal stress-induced hyperinsulinism is suspected, treatment is used for 2 to 6 months according to the clinical course. But if a permanent form of hyperinsulinism is suspected, treatment frequently is required, at least until puberty, and in some cases for life. We're now going to move on to talk about disoxide-responsive hyperinsulinism. And the first question that I wanted to review is, when is surgery indicated in the management of hyperinsulinism? We consider the indications for surgery for suspected focal disease because surgery is curative. So this should be the treatment of choice for focal disease. For non-focal disease, we reserve surgery for cases that failed all attempts to medical management. And we'll talk about medical management approach for these cases later. So the first step when considering a patient with disoxide-unresponsive hyperinsulinism is to distinguish between those with focal and those with diffuse disease, and to localize the lesion prior to referring the patient for surgery. So how do we distinguish between focal and diffuse hyperinsulinism? The clinical presentation can be helpful, but there are some subtle differences between focal and diffuse disease. Patients with focal hyperinsulinism may more frequently have lower birth weight, may present later because the disease may be milder initially with a lower glucose infusion rate requirement. But the most useful way of distinguishing kids with focal hyperinsulinism is the mutation analysis results. And that's why I was saying earlier how important it is to have a test that can give you results very quickly for the KATP channel genes, because a monoallelic recessive KATP channel gene mutation has a sensitivity of 97% for focal hyperinsulinism and a specificity of 90%. If we know that the mutation is paternal, the positive predicted value for focal hyperinsulinism is 94%. And then we move on to imaging. 18-fluorodopa PET has a sensitivity of 85% for focal hyperinsulinism, a 96% specificity, but it's almost 100% accurate for localization. So we use 18-fluorodopa PET not to diagnose focal hyperinsulinism, but to localize the lesion, because as you can see, the sensitivity of the genetic testing is higher than the sensitivity of the test. So that takes precedent. 18-fluorodopa PET is based on the fact that this L-dopa is stored in granules in beta cells, and when you have a conglomerate of beta cells in this adenomatous lesion, then you can image them by PET scan. This test is only available in a few centers around the world. In the United States, this is not FDA approved and therefore is done under an IND and a clinical trial. The synthesis of 18-fluorodopa requires a cyclotron, and the 18-fluorodopa has a very short half-life, so you basically need a facility with a cyclotron at close proximity of the institution to be able to accomplish this test. So just to illustrate the utility of 18-fluorodopa to localize lesions, here on the right, you have an 18-fluorodopa PET image of a diffuse cases. You can see on the left the liver and the gallbladder with the radioisotope concentrates. The radioisotope is excreted through the kidneys and the bladder that you can see in the picture. And on top of the kidney, the left kidney, you can see the pancreas with diffuse uptake of 18-fluorodopa. And this is in contrast to the picture on the left where there's an area of increased uptake distal in the pancreas. So this is the lesion in the tail of the pancreas. And below is the picture of a case with a focal lesion in the head of the pancreas. We use the PET scan in combination with the CT scan, and this allows to establish very clear coordinates of where the lesion is located. But this is only the beginning of the localization of these lesions. Surgically, the expertise of the pediatric surgeon is incredibly important to localize these lesions. They're very small, less than 1 centimeter. And once the suspected lesion is localized, the evaluation during surgery of frozen biopsies by a skilled pathologist allows for the confirmation that the lesion has been found, but also importantly that the margins are clear. So moving on then to the management of the disoxide unresponsive cases that are non-focal, I'll share some of the approaches that we follow. The second line of therapy is the somatostatin analog octreotide. We use it in doses up to 20 micrograms per kilogram per day subcutaneously. Other places may use higher doses. I think that higher doses, in my experience, are less likely to be more efficacious and are associated with more side effects. Octreotide can be used in multiple dosing regimens. It can be used every 6 hours. More frequently, we use it in twice daily dosing in combination with continuous gastric dextrose overnight. It can also be used continuously administered through an insulin pump. We do not use octreotide in babies that are less than 8 weeks of age because of the associated risk of necrotizing enterocolitis. And we do not recommend octreotide when there is focal hyperinsulinism. We think that those kids need to have curative surgery. The effectiveness of octreotide is limited by tachyphylaxis, which is very common in a series of 28 disoxide responsive cases published from, I believe, Germany. Octreotide effectively prevented the need for surgery only in about 42.8% of the cases. The side effects are likely dose-dependent and age-dependent and include suppression of growth hormone, TSH, and ACTH. GI side effects can be very common. Gallbladder stones are seen about 32% of cases, and again, are dose-dependent. There's transient elevation of liver function tests in about 46% of the cases. Thrombosis have been associated in about 2% of the cases. And necrotizing enterocolitis, while very uncommon in a series that we published in collaboration with the FDA, was about 1%, is very severe, and therefore we do not use it before 8 weeks of age. Another tool in the management of the disoxide unresponsive non-focal cases of hyperinsulinism is the use of continuous dextrose to either a gastrostomy or a nasogastric tube. More frequently, we use dextrose at 20%, and up to 10 milligrams per kilogram per minute is well tolerated through the gastric route. In addition to enteral dextrose, for older cases, longer-acting somatostatin analogs that can be dosed once a month are available. Typically, we use this only babies or children that are over a year of age and include long-acting octreotide that can be given intramuscularly at doses of 0.3 to 0.6 milligrams per kilogram, and lanreotide, which in my experience is more effective than long-acting octreotide, and is used in doses between 30 to 60 milligrams once a month. So in the diazoxide unresponsive cases of hyperinsulinism, genetic analysis results really determine the pathway to whether one is going to do directly medical management or imaging should be performed. If there are biallelic recessive or monoallelic dominant mutations in the KATP channel genes or the defects in glucokinase, this by definition is diffuse hyperinsulinism, and PET scanning is not considered in the path. So these patients go directly to intensive medical therapy, and if they are rendered unresponsive, then one should consider subtotal pancreatectomy. For patients in who the mutation analysis is negative, or there is a variant of unknown significance in ABCC8 or KCNJ11, or the hyperinsulinism due to Beckwith-Wiedemann syndrome, or for cases that have paternal recessive monoallelic ABCC or KCNJ11 mutation, PET scan is indicated to determine those that had a focal lesion that can be referred to surgery for lesion resection. And when the PET scan does not indicate a focal lesion, then we go back to intensive medical therapy, as we had described previously. Step 7, then, once one has determined the best treatment option for the patient, is ongoing monitoring, both for side effects of therapy, but also importantly for glycemic control, whether we use glucose meter or continuous glucose monitoring systems, and I'll share our experience with continuous glucose monitoring system, but also with inpatient evaluations to reassess whether the treatment is effective as the child progresses and ages, with safety fast or a protein tolerance test for those that have protein-induced hypoglycemia, monitoring of growth and development as well. So we were interested in assessing the utility of continuous glucose monitoring system for monitoring glycemic control in hyperinsulinism, and did a study in 14 children aged 15 to 67 months of age with persistent hypoglycemia due to hyperinsulinism. At the time, Dexcom G5 was what was available. We placed it for 2 weeks in a blinded fashion. And what we found is that there is a very high frequency of false positive flows. So we concluded that the continuous glucose monitor may be helpful for children with glycemic variability, but for children that are well controlled on therapy, for example, for diazoxide responsive cases, the use of continuous glucose monitoring can be more anxiety provoking than helpful in their management. Another limitation is the cost. This is off-label and very frequently not covered by the insurance. And this is the data. As you can see, the positive predicted value for severe hypoglycemia was only 15%. And for milder hypoglycemia was about 50%. So based on this data, we do not routinely use continuous glucose monitoring system in our population. This may change as the systems become more accurate. Step 8 in the management approach is then when to consider discontinuation of treatment. This is going to depend on the type of hyperinsulinism. So in an older patient with normal plasma glucose or minimal treatment, this should be considered. Definitely when resolution is suspected in the babies with transient perinatal stress-induced hyperinsulinism or in focal cases. But it's extremely important to demonstrate once treatment is discontinued that indeed the hyperinsulinism has resolved or has improved significantly, that treatment is not required. And this requires a fasting test. To finalize then, we will talk about the outcomes in congenital hyperinsulinism. And again, this is a historical overview of the outcomes. And I'm not going to go into details in all these studies. I just wanted to emphasize that throughout the decades and across the world, the neurodevelopmental outcomes of children with hyperinsulinism continue to be very poor. with about half of the patients having significant neurodevelopmental deficits. And this is by the fact that now we cure children with focal hyperinsulinism. But let's start with the surgical outcomes. So in focal hyperinsulinism, we can cure the great majority of cases when they're managed in an institution with the tools to make the diagnosis, to localize the lesion, and to effectively remove the lesion. The surgical outcomes for diffuse hyperinsulinism are not optimal. About half of the babies after near total pancreatectomy continue to have hypoglycemia. And this is why all attempts to medical treatment should be undertaken before recommending a near total pancreatectomy for these cases. In regards to the neurodevelopmental outcomes, as I mentioned before, about 48% of patients have issues. The data on the right is data from our Center for Surgically Treated Patients, illustrating the different manifestations of these neurodevelopmental outcomes. 21% of the patients have some behavioral issues. Speech delays were seen in 18% of the patients. Learning disabilities in 16% of the patients. Seizures in about 13%. Importantly, the poor neurodevelopmental outcomes are not limited to the diffuse severe cases, are also seen in focal and transient cases, as demonstrated on the right. Babies with transient hyperinsulinism, and as I show you with our data, have a frequency of neurodevelopmental outcomes of 30%. So this represents a challenge and an opportunity. We need to identify babies with hyperinsulinism early by screening infants at risk. We need to quickly establish the diagnosis and effective treatment, and we need to monitor them very closely to prevent hypoglycemia. And we definitely need better treatment options that we're hoping are on their way. Feeding problems are also very common long-term in these patients. In about 45 to 68% of patients, food aversion or refusal is seen. 75% of those with feeding problems require tube feedings. There are multiple potential causes of feeding problems, including this inherited to the disease, the anorexigenic effects of insulin, changes in gastric motility, the effect of the molecular defects on hypothalamic centers regulating appetite and feeding, particularly for the KATP channel defects. They can be secondary to treatment, as the adverse gastrointestinal effects of the medications that we use, the use of nasogastric or gastrostomy feeds or dextrose for glucose management, and of course the neurodevelopmental deficits. So to finalize, a few take-home points. The management of infants and children with hyperinsulinism requires a stepwise, comprehensive, and multidisciplinary approach to define genotype and phenotype, including diazoxide responsiveness, to determine the best treatment path, the individualized treatment approach to these patients, to assess the effectiveness of treatment, to closely monitoring side effects, complications, and glycemic control. And the treatment of these diazoxide unresponsive cases really requires assessment for possibility of focal disease, which is better done in a specialized center with a multidisciplinary team that can guarantee the cure of these patients by integration of genetic testing results, phenotype, imaging with 18-fluorodopa for lesion localization, and the expert assessment of the histology during surgery. Thank you very much for your attention. And here I have our referring line phone number, 215-590-7682. Please feel free to reach out to us by phone or by email at hyperinsulin@email.chop.edu. Thank you again for your attention, and I'll be happy to go over your questions.
Okay, Diva, it looks like we only have one question so far. The first one is, does monoallelic paternal mutation require a combination of a deletion of maternal chromosome 11 to lead to focal pattern histologically?
Yes, absolutely. A single paternal recessive mutation in isolation without the loss of the maternal allele would not result in hyperinsulinism, which makes it very challenging because we, cannot, because that second hit is somatic and happens only in the pancreas. We cannot make that diagnosis by testing peripheral blood. So the first hit, of course, we detect by the genetic testing. But in a patient without the loss of the maternal allele, those patients will be just carriers of hyperinsulinism.
Thank you. I encourage anyone else if they have any other questions. I have another one. Can MRI be helpful to distinguish focal cases when 18F-DOPA is not available?
That's a good question. And, because 18-fluorodopa is available, as I mentioned before, only in certain centers, people have attempted using other imaging modalities, but different from an insulinoma that is well encapsulated, a focal lesion of hyperinsulinism does not have a capsule. And therefore, the limits between the lesion and the surrounding tissue is not defined. So ultrasound or MRI are not effective in finding these lesions, which are commonly less than 1 centimeter in size.
Okay. Can cornstarch be used instead of continuous dextrose for babies that are unresponsive to diazoxide?
Cornstarch, I'm aware, is used by some of our colleagues to kind of bridge between feedings. But there are two issues with the use of cornstarch. The first is that the amylase expression in the gut to be able to digest the cornstarch is not expressed until close to a year of age. So in babies that are in the first few months of age, cornstarch is just not going to be digested and absorbed. The second issue is that cornstarch works very well for patients, for example, with glycogen storage disease, because those patients don't have an increased glucose requirement. So the slow release of glucose from cornstarch provides enough glucose to suppress hepatic glucose output in a patient with, for example, glycogen storage disease type 1, but does not provide enough glucose to prevent hypoglycemia in a patient with hyperinsulinism in which the glucose requirements are increased.
Can you give us an idea about the new drugs on the horizon?
Absolutely, I can share some information that is publicly available, and you can go to the clinical trials gov site. A ongoing clinical trial sponsored by Zealand Pharmaceutical is with the use of a new formulation of an analog of glucagon called dasiglucagon. So those trials are ongoing both in the United States, in Europe, and also in Israel. So I think if that trial is successful, that may be the next, the first alternative treatment available for hyperinsulinism. And I think the exciting side of these new drug developments is that they are being developed for hyperinsulinism. So for the first time, we will have new drugs that are approved for this indication, which has not been the case. As I said, Diagnostic was approved with a different indication and then later repurposed. And we still don't have, at least in the United States, a approval for octreotide or any somatostatin analog for this indication. So I do think that the tools that we're going to have available in 5 years are going to be different than what we have right now.
Okay, can you talk more about the fasting study on children who we suspect are transient? The timing and length of the study, is it 18 hours?
So for babies, let me see if I don't know if I understand the question correctly, but if we have a baby with suspected perinatal stress-induced hyperinsulinism, and we're trying to determine whether that baby needs treatment or not. And there's some occasions where we would not initiate treatment, and this is a clinical judgment. But basically, we use the duration of the fasting test, like how long can the baby safely fast without hypoglycemia, having into consideration that this may change, so you have to frequently monitor it. We use a period of time that is long enough that will give some safety parameters for the family. In general, if we are doing a safety fast to determine that the treatment is appropriate, we use 18 hours as the parameter of the duration of that fast to determine the treatment that we are implementing is effective.
Okay, how soon do you screen patients with high risk or SGA?
Yeah, so that's a good question, and that's outlined. I invite you to download the recommendations from the Pediatric Endocrine Society, which is free for downloading from the Journal of Pediatrics. The recommendation is to screen with a first glucose shortly after birth, so within the first 2 hours, and then to continue monitoring and making decisions whether further evaluation is required beyond the first 48 hours when we know there's that period of transitional hypoglycemia that can be seen in babies, in normal babies. So the diagnostic evaluation should be deferred to be done after those first 48 hours.
In a patient with diazoxide responsive hyperinsulinism, negative genetic test, what is the usual duration of treatment in your cohort?
So I don't know that I have a good answer for that question, because the frequency by which those patients had surgery was higher in the past in our institution. So if we go back 10, 15 years, most of those patients would have undergone a near total pancreatectomy. So their long-term outcomes are affected by that. We don't really have enough long-term data to know the natural history of those patients when not managed by surgery. But we will have in the short term, because we have changed our approach and other institutions have changed their approach. So I think we're going to have a better idea of the long-term outcomes when managed medically. What I can say is that 10% of patients with negative genetic testing from peripheral blood, a number of them that have undergone surgery at our institution, what we found was that they had somatic mutations in known genes. So the mutation was not found in peripheral blood, but was found in the pancreas. And because it was, kind of mosaic expression of those mutations, some of those patients were cured when we removed the part of the pancreas that histologically looked abnormal, and then we later proved that the mutation was only in that part of the pancreas. So no focal hyperinsulinism, but something that we here at CHOP call line hyperinsulinism, where there were histological confirmation that there was diffuse hyperinsulinism only in part of the pancreas. So line stands for localized islet cell and nuclei enlargement.
Okay, the next person thanks you for your comprehensive review and would like to ask if endoscopic ultrasound has been used. I know it is used for insulinoma, but not sure if anyone has used it recently.
So,
Second, okay, go ahead. You can answer that part.
yeah, so endoscopic ultrasound is helpful in localizing insulinomas, but the limitation would be the size of the baby. No one that I'm aware of have done it in an infant. So because of the size of the probes and the equipment, so I don't know if it would be helpful because there are limitations in the probability of just because of the equipment.
And the second part of the question is asking if you still do not recommend routine cardiac echo due to the concern of pulmonary hypertension with the diazoxide.
So in the Journal of Clinical of Endocrinology and Metabolism, there will be a publication available online very soon from the Therapeutic Committee of the Pediatric Endocrine Society outlining our recommendations for evaluation for side effects and monitoring of side effects of patients treated with diazoxide. And the recommendation would suggest that an echo is performed 1 week, about a week after initiation of diazoxide. So not necessarily in every baby before initiating diazoxide, but after initiation of diazoxide. What we do here at CHOP in terms of who gets an echo or not before diazoxide is highly dependent of the clinical picture. We do an echo in every baby that have very severe hyperinsulinism, typically because those babies with KATP channel defects do have cardiac hypertrophy, but not routinely in every baby before we initiate diazoxide, but a week later.
In the NICU, it's really hard to initiate medical management of perinatal stress-induced hyperinsulinism. When is the best time to initiate treatment? Some places wait too long to do it.
I agree that sometimes wait too long to do it. I think, again, this has to be an individualized decision according to the patient and according to the clinical, other associated clinical manifestations. So in my mind, if you have a baby that is in the hospital only because of the persistent hypoglycemia, I think that's time to initiate treatment. The baby's already a week old or 2 weeks old. You really should not delay discharge because of waiting for it to resolve, because it can resolve in a week, it can resolve in 6 weeks, so it's hard to predict. However, if you have a baby that is in the NICU because has feeding issues or is requiring, oxygen, then there's, in my mind, not necessarily rush to initiate treatment because, that you can wait until the baby is more stable to initiate treatment with diazoxide. This is if you're suspecting that really this is perinatal stress-induced hyperinsulinism. So I don't think that there's a fixed time. I think you have to individualize according to the case and have that discussion with the NICU. But it's important to have in mind that it's impossible to predict when it would resolve. So the baby should not be kept in the hospital waiting for it to resolve.
That's the last of the question. Oh, here comes another one. Baby with perinatal stress hyperinsulinism. It is very common and the challenging is to decide when to initiate treatment.
I agree. As I was saying earlier, this can be a challenge, and there may be disagreement with our colleagues from neonatology in what's the best time. But again, I think you have to have an individualized approach and evaluate the pros and cons of initiating treatment the best time. And you have to have in mind that once you initiate treatment, it may take a week before you're ready to discharge that baby. So that also should be taken into consideration.
What is the longest duration that a baby can be kept on glucagon infusion?
We have used it as long, I remember we have a case here of a baby with focal hyperinsulinism that has severe cardiac disease. So we couldn't take the baby to surgery until the cardiac defect was managed. And so that baby we treated with intravenous glucagon for 3 months. So that's as long as we have done it. I would say as long as you have to have in mind this is a temporary measure. So you can use it as long as you need to get to that next step, whether that next step is PET imaging and surgery for focal hyperinsulinism, or whether that next step is now the baby's 8 weeks and you're going to initiate octreotide. So I don't think there's a time limitation. As I said, the major limitation is that the glucagon precipitates in and crystallizes. So you have to work with your pharmacy to change that solution and the infusion set every 24 hours.
Okay, does anyone else have any other questions for Diva?
Well, I really thank you for your attention. We are here and happy to answer questions. As I said, please feel free to call our referral line 215-590-7682. Please also feel free to email us at hyperinsulin@email.chop.edu. We are available for second opinions. We have several outpatient multidisciplinary clinics that established patients can come for a second opinion to see our multidisciplinary team. We are available for discussing a case over the phone or by email. So always happy to help. I see that there are some new questions.
Yep, one's just thanking you for the presentation, and the next one says, I know Boston likely is working on it for their dual UMP.
So yes, the bihormonal bionic pancreas is taking advantage of some of the newly available, I guess, investigational formulations of glucagon. So I do think that we're going to have very soon the capability of using glucagon through it will require continuous administration through a subcutaneous pump. Again, thank you for your attention, and please feel free to reach out to us. We're always happy to discuss your cases and to be available by phone or by email. Our number again, 215-590-682, and our email is hyperinsulin@email.chop.edu.